Established in 1994, SAFAIDS is a regional non-profit organization based in Harare, Zimbabwe, with country offices in Pretoria, South Africa, Lusaka, Zambia, and Manzini, Swaziland. For the last 20 years, SAFAIDS has implemented programs in Lesotho, Malawi, Mozambique, Namibia, South Africa, Swaziland, Tanzania, Zambia, and Zimbabwe. SAFAIDS is recognized for its capacity to bring national lessons and experiences to regional advocacy and knowledge-sharing platforms. The objectives of SAFAIDS Adolescent Sexual Reproductive Health and Rights ASRH are to promote the sexual reproductive health rights of children, adolescents, and young people through the provision of comprehensive sexuality education with a focus on gender-sensitive approaches, to increase access for children, adolescents, and young people to clinical and non-clinical sexual reproductive health services, including community-based services, to create an enabling environment through advocating policies and legislation that promote the realization of the sexual reproductive health rights of children, adolescents, and young people in the selected countries and at regional level, and documentation as well as communication. Our implementation sites include Chaisa Health Center, Chipata Level 1 Hospital, Ngombe Health Center, Mandevu Health Center, Chazanga Health Center, Chipata Primary School, Mutambe Primary School, Simon Mwansakapwepwe Primary School, and Ngwerere Primary School. At SAFAIDS, we use the Social Accountability System for the ASRHR program and other programs under our organization. The Social Accountability System is a 5-stage process system which starts with the planning and resource allocation process. Under this process, the availability of public funds and resources to service providers and officials and how they plan these resources is scrutinized. The second process is the expenditure management. This process looks at the effectiveness of the public funds spent. The third process is the performance management stage. This process looks at how service providers perform in implementing their plans and if quality public services are delivered. The fourth process looks at public integrity and what mechanisms exist to prevent and what corrective action is taken in response to the misuse and abuse of public resources, while the fifth and final stage in the process is the oversight stage, which ensures that officials and service providers are called to account by oversight bodies for their performance. As SAFAIDS, we have done a number of programs, and key among them is a community hearing and in-country kick-off meeting. The community hearing program included 44 participants comprised of 19 males and 25 females, 19 institutions and partners, submissions of the findings of the social accountability process for the 5 health facilities to key decision makers, and commitments to responsibilities in improving ASRH services by all stakeholders. The in-country kick-off meeting included a total of 68 individuals comprised of 29 males and 39 females, representing 24 different partners, and the successful launch of the project. It also involved the orientation of key role players on the purpose and focus areas of the project in Lusaka, the creation and strengthening of the linkages to other services for service comprehensiveness, and the acquired buy-in from key government line ministries, including health, gender, education, and chiefs and traditional affairs. Under our ASRH program, we managed to train 35 social accountability monitors in comprehensive sexuality education using the POA. The 35 participants included 15 males and 12 females, and the training increased their knowledge on sexuality education. This led to the formation of Empowered to Be clubs, and 75 members joined the clubs, with a member ratio being 36 females and 39 males. 182 females and 186 males were reached with information through peer-to-peer communication, bringing the total number of those reached to 368. A total of 22 people, comprising of 5 males and 17 females, attended the project inception meeting, and jointly, partners developed activities and activity plans for the 2018 implementation year. Under our high-volume BASH system, 1,875 people were reached with information, 763 referrals were made. Accessing sexual reproductive health services, including 52 people who accessed family planning, 233 condoms were distributed, 70 people had their blood pressure checked, 100 individuals were tested for HTC, and 3 were found positive, and 4 people accessed pregnancy testing services. We conducted refresher training for children and adolescents in budget tracking and expenditure analysis, with 259 young people reached via social media platforms such as Twitter, budget and expenditure tracking analysis of ASRH at district and facility level, and we also conducted advocacy club meetings with E2B clubs, which is a total of 5 faculties, with a total of 254 members, of which 101 are males and 153 females. We conducted child-focused pre-budget meetings where advocacy issues were identified and grouped according to age categories. A total of 42 children and adolescents, comprising of 20 females and 22 males, participated in the meeting. Participating in the budget consultation meeting was the Ministry of Finance, and 27 people, comprising 16 females and 11 male children and adolescents, participated in the budget consultation process. Submissions on allocations to ASRH at district level were shared. SAFAIDS has a number of social accountability monitors in our areas of operations. The Social and Accountability Monitoring Program has helped many young people achieve their passion, which is to make a change in their communities, knowing that young people enjoy the maximum potential of their rights. This has led to many people knowing their rights and making it possible to accessing SRH services, as well as ensuring that there is a fulfillment of initial allocation of resources towards SRHR in Chipata community by holding the duty bearers accountable. The SAM program seeks to influence change in the governance system of Zambia towards increased allocation of funds towards SRHR. About 99% of adolescents' reproductive health services at district level are heavily funded by donors, and only 1% is supported by the government of the Republic of Zambia. For disadvantaged rural districts such as Mongo, adolescent health is not even planned for. Only about 0.005% of the national budget is ARH. Some of the challenges faced in dealing with issues of ASRH include the uncoordinated efforts among the CSO implementing such programs. Accessing documents from the different line ministries has been a challenge, and low literacy levels by the club members makes it difficult to analyze documents or articulate facility documents such as action plans. Some of the lessons learned in the course of our operations are that evidence-based social accountability is more effective and yield results. Technology influences office bearers' decision-making. Technology widens the coverage of information dissemination. Children can conduct child-tailored advocacy, and involvement of children and young people in planning and budgeting accelerates implementation. Some of our planned activities include national learning and sharing meetings, documentation of good practices and success stories, holding advocacy policy dialogue meetings for children, young people and policymakers on financing to ASRH programs, conducting national budget tracking and expenditure analysis for ASRH programs, and use data to advocate for increased budgetary allocation to ASRH programs, support advocacy weekly club activities in Chipata Health Zone, conduct a children's parliament and participate in the post-budgeting process and development of IEC materials on social accountability.